Good evening. My name is Teri Woodhull, and in 2 weeks I will officially be a 10-year survivor of ovarian cancer. I also have an inherited BRCA1 gene mutation. I'm here tonight just to share a little perspective from the patient's standpoint about genetics and the use of PARP inhibitors with ovarian cancer. You know, history of cancer in my family goes way back, breast cancer in particular. My mother died of breast cancer in 1990 at the age of 46. Her mother had breast cancer and her mother's mother had breast cancer. Based on that, when she died, her oncologist said to my sisters and I, we don't completely understand it yet, but we do think there is some sort of hereditary factor for families where breast cancer seems to be so prevalent. And Mayo Clinic is doing research in the area that you might be interested in checking into. Well, of course I was, because at that point I was concerned about myself and my children and this family history we seem to have. So in 1993, at the age of 30, I actually elected to have a prophylactic or preventative mastectomy. Now, the BRCA gene had not been identified quite yet, but the research was being done to see if preventative surgeries might help prevent breast cancer from developing in women in these families with high-risk family history. When the gene was discovered a little bit later, I actually did find out about it relatively soon. It was something I was following and I was very interested in. But it was called the breast cancer gene, and it was focused on breast cancer risk. And I thought I'd already done everything I could to protect myself from breast cancer. And so I really thought that getting tested would be more important for my daughter's sake, that I might find out if I was a carrier to see if I might have passed it on to her. And what my physicians and I missed as the science evolved is that it actually might be really important for me to know too. Obviously, as we know now, I would be at risk for other cancers, but it also might have some impact on my health should I be diagnosed with a cancer. So if you fast forward to 2010, when I was diagnosed with advanced ovarian cancer at the age of 47, I opted to get tested at that point because I wanted all the information possible to help me in combating this disease. It wasn't really a huge surprise that I did indeed have a BRCA mutation, given my family history. But it was important for me to know that because, yes, it did impact my family members and their potential risk, but it was going to also be a potential impact on treatment decisions that I was going to make. That's where the PARP inhibitors come into play. So when I was diagnosed in 2010, the PARP inhibitors were just in early stage development. They were in early stage trials, I think phase 1 and phase 2. But by 2015, when I recurred, PARP inhibitors had gotten further along in their research. And at my recurrence, I did go through treatment again, and I had a partial response. So my CA-125 went down, some of my lesions were gone, but I had some new lesions that had developed. So I had not a complete response, but a partial response. And I had a decision to make. I could either wait and just see if those lesions progressed or if they stayed stable for a while, and then I would do treatment again, or I could consider doing a maintenance treatment. Something that I could do actively to try and keep those lesions from progressing for as long as I could. Now, maintenance wasn't available as a regular treatment. It was only available through trial. So I opted to enroll in a clinical trial. I actually went to San Francisco to be a part of the trial. So I traveled every 4 weeks to San Francisco to be a part of this trial to get the PARP inhibitor. And the first 8 weeks of taking the PARP inhibitor were actually pretty brutal. I had just finished treatment, so I was weak. I didn't feel very good. The PARP inhibitor made me nauseous. My blood counts were low. My counts dropped rapidly, and I had to come off for a week. I had a lot of fatigue. But as we worked through that first period, it was amazing how my body started to adapt. We dealt with the blood counts by lowering my dose, and the nausea we dealt with by finding different things to relieve the symptoms. We actually discovered with me that it was more of a GERD or indigestion kind of nausea, and not the kind of nausea that you would take anti-nausea meds for. And the fatigue seemed to get better. It was like my body got used to the PARP inhibitor and just seemed to deal with it better. So it wasn't without side effects, and it certainly wasn't without hassle, because I had to travel to San Francisco every 4 weeks to be a part of that trial. But for me, it was well worth it. I actually had 3 years of stable disease on that PARP inhibitor. And during that 3 years, I had an incredible quality of life. It was time during which I was able to accomplish many things that had been on my bucket list. You know, those things you say, oh, when the kids are older, or when I retire. I went on an African safari. I hand glided over the Swiss Alps. I got to see my kids graduate from college, and just be a part of the everyday lives of my family and friends. So many things that I cherish and I know were very important to me. So for me, that decision to go on maintenance therapy was one that was relatively easy. But I know that isn't the case these days for everybody, especially because it's become more complicated, as PARP inhibitors now have been approved not only for women with BRCA mutations, but also for those mutations in their tumor and those without mutations. And they've been approved for after frontline treatment as well as recurrence. So the decision of whether or not to do maintenance is something where I believe you as a patient have to be an active participant. You really have to be a partner with your provider and talk to them about what's important to you, talk to them about your concerns, whether or not, you know, what your goals are and what you want to accomplish. For some people, they may opt to not do maintenance. I have friends that have made that decision, and that's the right decision for them. They'd rather wait and have the PARP inhibitor as a potential treatment option later down the road and simply have a break. Because we know when we're done with chemo, we just want it behind us, right? A lot of times we're counting down those treatments. I have 3 left, I have 2 left, I have 1 left. And you sort of get your eye on that and you just want to be done. The important thing is with those options, you have choices. And in order to really make sure that those choices are right for you, you have to be an active participant. And that's not always comfortable. We look to our providers for answers and we're afraid and we don't want to make the wrong decision. But if you are really an active participant in that conversation, share your concerns together with your provider, the decision that you make will be the right one for you. Thank you.